We're here at the newly renovated Miami Beach Convention Center for the Open Forum for Aesthetic Plastic Surgery at the ISAPS. This event happens once a year and attracts plastic surgeons from all over the world to share their knowledge and experience about new aesthetic surgery techniques. And we're here today with Dr. Fausto Viterbo from Sao Paulo, Brazil. And I'd like to introduce you to him. So Dr. Fausto Viterbo, I'd like to know, why did you choose this field of specialty?
Everything started in my Ph.D. thesis in 1992 when I discovered a new way to connect peripheral nerves. Peripheral nerves, when you have a cut in a peripheral nerves and you have both endings, you can suture, you can connect them again, and the axons will grow to the distal ending and the nerve will be good again. But sometimes you have a lesion in a nerve and you don't have the proximal ending, so you have only the distal ending. And so what we had to do, it was to cut a healthy nerve in the neighborhood and use the proximal ending and connect end to end. I discovered in my Ph.D. thesis that we could suture the distal ending in the lateral aspect of a healthy nerve in the neighborhood. And this donor nerve will allow the axons grow laterally without harming this nerve. And this was a revolution because any nerve may be used as a donor nerve. And so since then, I don't stop thinking about new possibilities to use donor nerves to treat new disease, new problems. I start using in facial palsy, doing the cross face with end-to-side neurography. The traditional cross face, we put nerves connecting the healthy side in the face with the paralyzed side, but cutting nerves in the healthy side and doing end-to-end. So with the end-to-side, I start doing the cross face and put end-to-side in the healthy side and bring axons to the paralyzed side without harming the healthy side. And then I use this in paraplegics to treat the lack of sensation and that produce pressure ulcers, and this is a big problem in paraplegics. So I used to put nerve grafts in the intercostal above the lesion, the spine lesion, and put in the skin, and these patients didn't get pressure sores again, pressure ulcers again. I use this tool to patients that lost the smell capacity. I put a nerve in the side of the supraorbital nerve and put the nerves in the roof of the nasal mucosa, and the patient regain the capacity of smelling. And this opened new techniques from other colleagues to use in the end-to-side to re-innervate the cornea, to re-innervate brachial plexus lesions, and other applications. But then in 2011, we had this idea, and we developed with our group in Botucatu University of Medicine with Dr. Trindade, his son Trindade Filho, André, and Wagner, we create a team to study this new possibility to use the end-to-side in patients that had prostate cancer. And so we put nerves connecting the femoral nerve in the inguinal area with 2 nerve grafts end-to-side in the femoral, and the other ending of these nerves we put one inside the corpus cavernosus in the penis, and the other nerve in end-to-side in the dorsalis penile nerve. Bilateral, so 4 nerve grafts. And the result was spectacular. 60% of these patients regained the full capacity of sexual activity with penetration and with a normal life. And the other 40 that doesn't get this full capacity, but present many other signs like nocturnal erections, flaccidity erections, semi-rigid erections, and this make them feel alive again. And they told us, oh, my life changed a lot because I have penile reactions when I see good, beautiful things, and I feel much more comfortable and happy. And so this changed our lives, both the patients and the doctor. This is very stimulating for us.
What is your professional experience as a doctor?
As a doctor, I did general surgery residence, and then I did plastic surgery residence. And in the plastic surgery, I do all the cosmetics procedures, faceliftings, breast reductions, and abdominal and liposuction, everything. But beside this, I start doing facial palsy treatment since 30 years ago, and I developed techniques to facelifting, to facial palsy. I developed techniques to facial palsy too, and it's very interesting. It's a field that I like too much to work on facial palsy too. Especially now we are doing the surgery in young kids, like 1 year, 2 years, and put nerve grafts inside the zygomatic muscle, that is the main muscle to smiling. And so doing this, we save this muscle from atrophy, and the smile is much more natural and with no modifications in the anatomy of the face, because we use the original muscles. And we do microsurgery in peripheral nerves, like I told you, to regain smelling, in facial palsy, nerve graftings, in paraplegic, and now in penile reinnervation for impotence. Penile reinnervation impotence is used in patients that had prostate cancer and got impotence, but there are another group of patients that had trauma, hip trauma, especially motorcycles, and they broke the hip, and so during this fracture may occur a lesion in the cavernous nerves. So we do the same procedure. We put nerve grafts inside the corpus cavernosus of the penis, and the patient had good results too. And another indication is the impotence by the elderly patient, that we put nerve grafts the same way.
Now, what led you to this innovative discovery?
The experience using nerve grafts in other fields, like facial palsy, like the smell, the mucosa, nasal mucosa reinnervation, that now we are thinking with the end-to-side neurorrhaphy possibilities, we are thinking like an electrician. We imagined that we have problems with this light in this area, but this area the light is okay. So you put a cable and connect both lights together. We think like this. So if we have part of the body that doesn't work properly as motor or sensation, we can use nerve grafts connecting both. With the endosynurography, this is possible nowadays because you don't lose anything, you just gain. Another new applications that we are going to start in 2 weeks is the reinnervation of the areola in patients that put silicone implants and that has decreasing sensation. We will put nerve grafts in the areola. We don't know the results yet, but based in other experiences, in other techniques, with endoside, we are very positive thinking about this.
Who makes a good candidate for this surgery, and what is the right time to start thinking about it?
Yeah, if the patient had a prostate cancer, the urologist do the prostatectomy, and so these patients nowadays with the robotic surgery, the risk to harm the nerves are very low, but we have some cases with problems even with the robotic surgery. So we recommend these patients to wait at least 1 year. If in 1 year nothing happened in terms of erection, then they are candidates to do the penile reinnervation. The patient should present good health. We do a preoperative full checkup about cardiovascular status and blood analysis and everything. If it's in a good health, he's a good candidate.
What type of anesthesia does the patient receive with the surgery?
We can use both, general or epidural. But the great majority, we prefer general because it's a long surgery, around 6 hours in average, so the patient feel more comfortable with general. But we can use epidural.
And what is the success rate of the surgery?
Yeah, with this surgery, we got 60% of full recovery in terms of sexual capacity. So 60% of the patients returns to have full penetration. In an average of 13 months, we have patients that had these results with 3 months and other patients later. But the average, it's around 1 year and 1 month.
Is there a risk?
Yes, as any medium-sized surgeries, there is risks. But the risk is very low because it's a non-invasive surgery. The surgery is done under the skin. It's 2 incisions in the inguinal area and dissect under the skin. 1 incision in the base of the penis, a 5 centimeter incision in the base of the penis, and we connect both the 3 incisions to pass the nerves. And so it's out of the abdominal cavity. It's superficial. And the nerves, the same way, are removed under the skin. There's both sural nerves. And taking off these nerves, what happens? These are sensory nerves. And so the patient will lost the sensation in the lateral aspect of the foot. If you imagine this is my foot, in the lateral aspect, only this area the patient will lose the sensitivity. And so we explain this to the patients, but they doesn't complain about this, because this is nothing with the possibility to have erections again. This technique, it doesn't harm, it doesn't change the penile anatomy. You know, is a surgery that doesn't change anything in the penis, because we do just 2 millimeter incisions in each side of the penis and put the nerves. And so the anatomy of the corpus cavernosus, of everything, it's normal. And so if this surgery doesn't work, the patient has the possibility to be operated and put a silicone prosthesis. So what we do in these cases, we recommend these patients to look for their urologists and ask them to do the surgery, because we don't do this prosthesis implants. We are not urologists, we are only nerve microsurgeons.
How long is the recovery time?
Yeah, it's in average 6 hours. It's a microsurgery procedure, so we use microscopes to do that, and we work with 2 teams. One team works removing the nerves and closing the skin, and I and my assistant go to the nerves and to the penis and do this job.
And how long does it last? Does it need to be redone?
The patients we have that got full erections, they keep with these results until now. And so we suppose that as we reconnect this new neural via, it's forever. But for sure, as any nerves will, with the elderly, all the nerves will decrease his capacity, and probably these nerve grafts will decrease too. We don't know yet about this, but the patients we did surgery keeps with the same result.
And where is the surgery performed?
Yeah, I do the surgery in São Paulo City, in a big hospital that's called Hospital Albert Einstein. That's the biggest and the best hospital in Brazil, one of the best in Brazil, and has all the facilities, and we are doing the surgery there.
How has it changed the lives of people?
Totally. We apply some questionnaires about life quality, and 100% of the patients, even the patients that didn't regain the penetration capacity, answered that the quality life definitively changed for better. They are feeling much more happy and normal again, feeling normal. You know, the penile reaction is something for the man very important. You know, to have nocturnal erection is very important. It's of the nature of the man. When these patients lost this and this regain again, they are so happy, very happy. And it's a life-changing, yes.
Wow, this is revolutionary. It needs to be heard by people all over the world. It's a life-changing procedure, and I am so thankful that you're here today to share it with us. Thank you, doctor. Is there anything else you would like to add?
I'd like to say that this surgery is something new, is some revolutionary. This technique we are presenting in many meetings. We present this year in the American Urology Society meetings, the American Urology Association in San Francisco, and the colleagues that watch like it very much. We are presenting in many meetings, and the response of the colleagues are very positive, and this is something that this work is published in the British Urology Journal International last year in June, and I think this is a very positive surgery.
I wanted to thank you very much, Dr. Viterbo, for being with us today. Thank you for sharing your professional experience, and I really, really appreciate your time today. Thank you.